Good afternoon, everybody. On behalf of Fortis Healthcare, I'd like to invite all of you to this important panel discussion on the emergence of antimicrobial resistance, solutions, and the role of the community to tackle this challenge. To introduce the subject, antimicrobial resistance occurs when microorganisms, that is, bacteria, viruses, fungi, and parasites, stop responding to the antimicrobial agents that are used to treat them. As a result of this, the patient does not respond to the infection that he or she is being treated for, and this results in the spread of multi drug resistant organisms and severe illnesses in the community and sometimes resulting in death. The World Antimicrobial Awareness Week is a global campaign that is meant to create awareness about this important aspect. We have a global crisis of antimicrobial resistance. This is an initiative from the World Health Organization, and this is our intention to actually bring about awareness about this important topic. This is celebrated for a week from the 18th to the 24th of November every year. The World Health Organization's theme for this year is Educate, Advocate, Act Now. This panel is our contribution towards this goal. To introduce the subject with a survey that was conducted by the Fortis Healthcare in the community, we had 4,500 respondents, and some of the results were actually quite striking. I'm only going to highlight one or two of the important aspects. 81% of the respondents were unaware that there are infections caused by bacteria and viruses, and that antibiotics would only act in bacterial infections and not for viral infections. This is an important finding. 62% self-medicated, again, a very high number. Not only did they self-medicate, but they self-medicated for mild infections like flu, common cold, etc., which are caused by viruses and don't really need treatment with antibiotics. So there were no discussions in this group, as we found in 62%, with the doctors on whether you need an antibiotic or otherwise. So in a viral infection, you're actually pouring down an antibiotic like a vitamin with tremendous side effects. So it is very clear that the time to act in this important area is now. And in doing so, we have an eminent panel with us today to discuss this important topic, and raise awareness about this so-called crisis. The first panelist that I'd like to introduce and put forth a question to is Dr. Prakash Vaidya. Dr. Vaidya is a very senior pediatrician with Fortis Healthcare. Dr. Vaidya, my question to you is, in your practice as a pediatrician, when you see a very sick child with fever, how do you explain to the patient's parents, who are often demanding that antibiotics are not magic bullets?
So I think the key lies in two things. One is getting a good history, and secondly, giving them time to address their queries. A history, once they tell me that the child is very sick looking now, but when the fever is down, he is playful and active, interfebrile period. That straight away tells me that this is most likely not a serious bacterial infection, but a viral one. The second thing is that I like to address what the parental fears are, because many of them feel that higher the fever, more serious is the infection. So we first disabuse them of that idea. It is nothing to do with the height of fever. It is everything to do with the interfebrile state. The second thing is that we have to explain that fever is not really an antibiotic deficiency state by any means. Apart from that, I like to address what are their fears. They are worried that the fever is too high, it will go to the brain and the child will get a convulsion. So these are unspoken fears which we address. And I'm at pains to tell them that A, hardly 8% get convulsions. B, viral or bacterial, it doesn't mean that by giving an antibiotic a convulsion is prevented. And C, by giving an antibiotic indiscriminately, I am likely to do more harm than good to your child unless I know the cause of the fever. So I think it's a frank discussion, transparently done. And sometimes, honestly, I don't know the cause of fever on day one of fever. So I'm very quick to tell them that this is a fever without focus, and we have to let it play out before we decide to give the specific treatment, and we may do investigations if required. So I think it's a question of giving time to the family as well as addressing what their main fears are. And that helps me to cut down indiscriminate use of antibiotics. So I think I have them on the same page once I explain all this.
I don't think you have an easy task at all when you're dealing with sick children because the parents are so impatient, they're actually down your throat. The second question, again, I'd like to address to you is in continuation with what we have discussed. Are there any specific investigations that you'd like to ask for that can reliably tell you whether antibiotics are required or not required in a particular case? Over to you, Dr. Vaidya.
So, thank you. Again, I have to emphasize to the parents that what is most important is a proper history and a good clinical examination. Investigations, though somehow parents seem to have a lot of faith in the printed sheets, it's really not something that can be interpreted out of context. One thing. Secondly, investigations are not a fishing expedition where you randomly do them so that you can come to some sort of a label. I explained to them that investigations are done to either rule in or rule out a diagnosis. So if I really suspect a viral fever, then probably I may ask for investigations just to see the consistency with that. But to answer your question, there are some viral infections which are straight away revealed by an investigation, like dengue. On day one or day two, we would get the dengue antigen positive NS1. So then I straight away know the answer. Or I may get a malaria positive immediately, and then I know the answer, and then it straight away tells me that this was not really a case for antibiotics. I make it a point in my practice not to start antibiotic unless I do at least a urine routine, because urinary infections are notoriously easy to miss in children. They do not have urinary symptoms, so we can't afford to miss a urinary infection. Again, a report gives you an answer on a platter, and though you will send a culture before starting antibiotic, a report really is helpful. What I want to make it a point here that they may come with some irrelevant reports like a Vidal on day one, which is totally irrelevant, and they say, "Look, my child has typhoid," because the lab has bundled it with some other tests. So that is again a problem, that these investigations are irrelevant. The other thing is, somehow parents think that a high count or a high CRP is a peg on which you can hang your antibiotic therapy on. And this is certainly not the case. If it's isolated, high CRP, high count, but the rest of the picture is viral, I tell them that we do not go by the investigations alone. And there are situations where investigations help, which I already mentioned. The final thing is a blood culture. Of a blood culture grew organism, I'm 100% sure, but culture takes time. It takes days for it to grow, and I have to meanwhile keep them at their fears at bay and explain to them that my not starting an antibiotic is not a disservice to their child, but we can safely wait and see how the disease evolves out. So I think there is a role of investigations, but investigations have to be seen in the right perspective.
I think that was so well worded by you, Dr. Vaidya. We'll move on to and we'll come back to the role of investigations and other things. But it's important again to remember that there are simple things, simple tests that often give you a diagnosis. And one of the important tests today is blood culture, and not just depend on the lab results. Many people just look at the labs and say, "Look, I have this infection, I have that, and doctor, please give me an antibiotic." So that was really very, very useful information. The next question, I'm going to move from one panelist to the other, is addressed to Dr. Anita Matthews. Dr. Anita Matthews is a senior consultant in internal medicine and also in infectious diseases at the Fortis Mulund Hospital. My first question to you, Anita, is why is antimicrobial resistance a concern in your practice, and what causes drug resistance? This question is addressed to Dr. Anita Matthews. I think there's some
Hi,
technical
ma'am.
glitch. Yeah.
Yeah, I just managed to get in to the call. Yeah, sorry about that. Yeah. Yes, ma'am.
So, Anita, the question I want to ask you is why is AMR a concern in your practice, and what causes drug resistance? This is my first question to you. Over to you.
Madam, the AMR is going to be important in the practice because majority of the patients that we'll end up seeing are either because of some kind of acute fevers or chronic fevers. Acute fevers, generally we need to look at whether there is a need for giving an antibiotic or to withhold. I mean, without a diagnosis, unless and until the patient is extremely critical, one wouldn't want to start off with an antibiotic. These patients who come with chronic fevers, like which is what we call as fever of unknown origin, these are the major concerns because they would have gone to multiple places, may have been given antibiotic, which may or may not have been indicated. So by the time they come to us, they have already received multiple antibiotics, and the chances that they are likely to be drug resistant is fairly high. So this becomes a major concern for us, because then we would land up treating patients with a higher molecule because we already have a drug resistant bug in the background. The second part of your question was,
What causes
Madam?
drug resistance? What are the causes of drug resistance?
One of the major concerns here is that giving multiple antibiotics obviously would be making the bugs more likely to have a mutation, which would probably be able to counter that antibiotic better. It's a survival of the fittest. The same logic will apply even for the viruses or the bacteria. So you're going to have a drug resistance which would be on the rise just because of giving multiple antibiotics at different time points. So that is one. One of the other causes is that you have your various livestock which are there. They all are given antibiotic to reduce the risk of infection in the cattle and the other livestock that you have. That increases the risk of antibiotic resistance in the community as well. Your effluents of the pharma company, they also would probably pollute the water, and that also would be one of the contributing features and the factors as well. And poor hygiene, this is going to be one of the factors as well to increase the risk of drug resistance, because you would develop multiple infections because of poor hygiene, and that would make you more prone for more antibiotic treatment.
I think you've brought in some very important points about the environment, about livestock. There are so many things that the public is not aware of. Like we have organic items today, we should also have antibiotic-free foodstuffs available to us in various stores. The next question, again, in continuation with what I asked you, Anita, is why is it so important not to take antibiotics from a previous prescription? Say you have a fever and the patient comes back to you, or rather, the patient doesn't come to you. The patient says, "Oh, I have this antibiotic prescribed. Let me take the same prescription again." What is so important about this that whether you should not take a previous prescription?
So the infection that you could be harboring presently as against whatever was there last time can be different. The bugs could be different between the two set of had. Uh, there could be a resistant organism this time around which was not there the last time, or vice versa. The whole infection could be viral, it need not be bacterial. In fact, viral infections are more common than bacterial infections. So taking an unnecessary antibiotic which could have been possibly prescribed in the last occasion, or for that matter an antifungal or an antiviral unnecessarily which was given to you the last time point without having a definitive diagnosis as to what are we dealing with this time, is obviously not going to be it's counterproductive. It's not effective at all. It's counterproductive. Unfortunately, in our country, we also get antibiotics over the counter. So somebody can go with a past prescription and then still get the same set of medication.
So the lesson to learn from what Dr. Matthew said is don't be your own doctor. It's important to talk to a doctor. I think we've all spent years studying medicine, and the community should make use of that fact. I'll move on to the next panelist, Dr. Kirti Sabnis. Dr. Kirti is an infectious diseases physician with the Mulund Fortis Healthcare. My question addressed to you, Dr. Kirti: what guidelines do you follow for the use of antibiotics in common infections that you see in hospitalized patients?
So there are various parameters we decide to start on antibiotics for a particular patient. First is a syndromic diagnosis, what the patient has, because bacteria are there everywhere on our skin, in our tummy, in our urine. So we decide regarding the penetration of the antibiotic also changes, the dose changes. So we first decide whether it is a bacterial infection or a viral infection. It's very important that the viral infections won't need antibiotic. And so even people nowadays want a very fast cure. They want to get better quickly, so they want to take antibiotic and they feel that all infections can get cured, but that's not the fact. So we address first what is the syndrome, where is the infection source, and accordingly we decide our dose and duration of antibiotics. When the patient is better, is able to take orally well, we might shift from an IV antibiotic to an oral antibiotic, which can be managed at home. So at this point, it is very important that even if you are feeling better, that patient should complete the antibiotic course or duration prescribed by the doctor, because each syndrome, like suppose a lung infection, pneumonia, urine infection, UTI, has a specific course of a duration of antibiotic required to kill that bacteria completely. If people leave the course, like if they're feeling better and when they're discharged, they stop taking the antibiotics which is prescribed, there can be increased resistance because the bacteria are not fully killed, and whatever partial population is remaining will cause, definitely have a resistance because they are growing in the presence of this particular antibiotic. So first of all, it is important whether it is really required, that is syndromic diagnosis, and how many days it is required. There are guidelines which are available, and it's a part of the medical training which as an ID physician we do.
So it's very clear that diagnostics is important in treating any infections. And again, let the doctor decide. In hospitalized patients, it's much easier for doctors to control things. But when you move on to the community, I'll move on to the next panelist, Dr. Farah Ingle. Dr. Farah is an internal medicine consultant with the at Vashi. Dr. Farah, my question to you is: in your practice, in particularly in the community and in outpatients, how do you manage community acquired infections?
Yeah, good evening. So, community acquired infections are the ones which are acquired outside of the healthcare setting or are diagnosed within 48 hours of admission to the hospital. It could be now, community acquired infection could be either bacterial, viral, fungal, protozoal, anything. So, the evaluation has to be a comprehensive approach. It begins with thorough detailed history taking, general examination, systemic examination. So once you are done with the diagnosis, which is a provisional diagnosis, at the end of checking your patient, then you start a workup. Workup should be started quickly so that you diagnose things properly early and start treatment accordingly. As we know that this community acquired infections could be either mild or it could be moderate or serious infections. So the routine blood test which we do is normally the CBC, CRP, other parameters, maybe OTPTs, depending on where the site of infection you are suspecting. There can be radiological investigations, like if it's a chest infection, you do an X-ray chest. Sometimes you have to do a CT scans. If the patient is febrile, you should do a blood culture. But important here to point out is the blood culture has to be collected immediately before we start the antibiotic. Serious patients require admission. Milder cases can be managed on OPD basis. Normally, after we are done with collecting the samples for testing, we do an X-rays. Sometimes sputum cultures, gram stains and cultures are required. Urine routine and culture is required if you are suspecting chest or urinary tract infection. And then we start with the empiric therapy once the diagnostic workup is done. So this empiric therapy in most of the cases is initiated based on the most likely pathogens and the local sensitivity pattern. That is the antimicrobial resistance pattern. Now, if you see the chest infection, mostly it could be streptococcus pneumoniae, it could be staph, it could be H. influenzae. So normally we start with monotherapy initially. If the patient is a mild case, we can start with amoxicillin, we can start with azithromycin or doxycycline. Also, we have to take into account if it's an adult patient with comorbidities like diabetes, COPD, liver or kidney disease. Accordingly, we have to adjust the medication and monitor for the sugars. Combination therapy can be given in those patients like amoxicillin, clovinic acid with macrolide. If the patient is serious, patient requires admission. If the patient is admitted in the ICU, then we start usually with beta lactams with macrolides, or we in very very severe case even we have to give higher antibiotics like meropenem and all, piperacillin, tazobactam or meropenem. Now, in milder cases, usually the duration of therapy is about 5 days or at least for 48 hours till there's no fever for 48 to 72 hours or the symptoms are improving. And also is important is the supportive care. So good nutrition, hydration status has to be maintained, and we have to monitor supportive care. Rest is important. Oxygen, if required, may have to be given for the admitted patients. And steroids for serious patients are not routinely recommended except if the patient is very serious and is in refractory septic shock. And for other patients, I would stress also on the preventive measures like vaccination. We have vaccines available for pneumococcus and influenza. That's very
If I can
important to
interrupt, we'll talk about the vaccines a little later, Dr. Farah. But there's
find.
another important question. There's another, sorry for the interruption. There's another important question I'd like to ask you. It's very clear that in the community decisions are difficult, and there is a range of antibiotics which are specific for different purposes. But Dr. Farah, as an organization or a hospital, how can we contribute to this problem of antimicrobial resistance? Over to you, Dr. Farah.
Yeah, thank you so much. See, organizations and hospitals play a very crucial role in combating antimicrobial resistance by implementing robust antimicrobial stewardship programs or AMS program. Now, these programs usually focus on optimizing the use of antimicrobials to improve the patient outcomes and to minimize the harm and reduce the spread of resistant pathogens. So we can have like education and training, continuous education for healthcare professionals, monitoring and surveillance, antibiotic stewardship teams can be formed. Then we have to promote infection prevention, control. We have to focus on how to optimize treatment. All those goals of AMS has to be followed, like optimize clinical outcomes, minimize adverse effect, reduce antimicrobial resistance, cost effectiveness is important, promoting health, public health is important here. So we have to develop these programs, educate and train our staff, monitor them, and optimize prescriptions. So all this together, by implementing this robust AMS programs or AMS strategies, hospitals and organizations can play a pivotal role, I can say, in combating AMR, preserving the efficacy of existing antibiotics, and ensuring sustainable healthcare practices. That's what is from my side.
Thank you. Thank you, Dr. Farah.
Thank you.
We've looked at the community, we've looked at hospitalized patients. Now we move to a very important area, and which is the critically ill patients. I'd like to introduce and invite Dr. Vaishali Solao. She heads the intensive care department at Fortis Healthcare. Dr. Vaishali, my first question to you is, in critically ill patients, how do you decide on the use of antibiotics?
Thank you, Dr. Rohini. Good evening. So by the time the patient reaches an intensive care unit, he or she is usually extremely sick and already has one or more organ failure. Half of the patients who need ICU will have some sort of infection, which may be unclear at the time of presentation. And we call that as septicemia, by which it means that the infection has already spread into the body. Now, this septicemia is a life-threatening condition with a mortality of anywhere between 10 to 40%, depending upon the number of organ failures already present. Now, out of all these situations, this is a critical situation where one doesn't have time to wait for investigations, results, and then choose. So in the beginning, one has to choose empiric antibiotics. Usually very broad spectrum and highly potent antibiotics are chosen, because the patient is not going to give you a second chance. Once you choose that, and it's usually a combination of antibiotics to cover gram-positive bacteria, gram-negative bacteria also. Once the antibiotics are started, for the next 48 to 72 hours, we continue our search for the focus of the infection and for the bacteria, that is the bug which has caused that infection. At the end of those 48 hours, if we have a clear bug, we have a clear site, then we rationalize that prescription and narrow it down to target only that bug. If for some reason 50% of them will have negative culture despite having an infection, but is responding to the combination which we have already started, then we continue the same combination for around 8 to 10 days, depending upon the patient's response. Unfortunately, sometimes they don't do well and start deteriorating despite your initial empirical combination. And that is when we have to upgrade the antibiotics further without a guidance of the culture. Mind you, there's a fourth scenario, and that is at the end of those 24 to 48 hours, we may actually realize that it is not a bacterial infection, but a simple viral infection. And this does happen in cases of pneumonia, even if they are severe pneumonia requiring ventilator. Many of them turn out to be viral, and in that scenario, we stop the antibiotics with a confirmed diagnosis of a viral pneumonia. Now, once this prescription is not under the control of a single doctor, because individuals can go wrong, So, at a policy level, every hospital, and especially at Fortis, we have the antimicrobial stewardship program. And Dr. Kirti, who's also a co-panelist here, will audit all my prescriptions in the ICU for the appropriateness of the antibiotic, so that a rational antibiotic use is ensured inside the ICU, which is itself is a very important step towards restricting the antimicrobial resistance in the ICU. So though in the ICU we have to be very aggressive, there is still a scope of rationality, and a multidisciplinary approach to maintain that rationality is very important.
I think you've answered part of my next question's answer as well. But it's the situation in critically ill patients is different, and that we don't wait for results of investigations. We do start antibiotics empirically. That is what Dr. Vaishali has said. But let me put it across to you very bluntly: how grave is antimicrobial resistance in the ICU, and what measures are we taking to fight this phenomenon, which is a crisis today?
So this problem has really become a crisis in intensive care unit. I have been in intensive care unit for nearly 25 years now. And this problem now has grown not only in the quantity, but also quality. I'll just explain briefly what I mean by that. When I say quantity, that the number of infections caused by these superbugs, the sheer number is doubling every 10 years. When I say quality, the antibiotics, which used to be very effective and highly potent during my training days, which was in the early 2000s, I'll give it a name which is called as meropenem or carbapenem, today has become quite ineffective in most of the superbug infections. So both in terms of the quantity and the quality of the infections, we have reached crisis levels all over the world, and especially in India. Now, these superbugs, basically, they're very difficult to treat, the infections caused by these superbugs. And that is why all this endeavor to enlighten the community, this AMR week, because every individual needs to understand what is a superbug, how does it impact an individual, and what is its impact at the society level. These superbug infections are extremely difficult to treat, so they increase your patient's ICU stay, and sometimes actually also give an adverse outcome. Now, how to combat these superbugs in the hospital scenario? Well, basically the hospital at a policy level needs to have good infection control practices in place, and also a good antimicrobial stewardship program in place. So this is two-pronged. They prevent infections, and if they still happen, there should be an extremely good multidisciplinary approach towards treating these superbug infections. But yes, the
Thank you,
problem
Dr.
is
Vaishali.
extremely severe all over the world, and India is no exception to that. Thank you.
Okay. Thank you for that. So it's very clear that we don't have too many drugs left. So what are the other measures we are looking at? To that effect, I'd like to ask Dr. Anita Matthews another question. What is the role of hygiene and good infection control practices to control antimicrobial resistance? Dr. Anita Matthews.
Well, it's going to be extremely important to have the hello.
Hello, I think we just lost you. Are you back? Yeah.
Yeah, yeah, I'm back, ma'am. I have some problem network connection from my end, which
Okay.
is a
So
bit
you're
of an
talking
issue.
about
Sorry
infection
about
control
that.
practices to control AMR.
Yeah. So as I was saying, it's extremely important to really have an infection control practice so that you can have a reduction in your antimicrobial resistance. One of the first things that we would be looking at is going to be hand hygiene, because that's one of the ways in which the infection is known to spread. So we call it as a 5Fs, one of the 5Fs of the infection control. So that's going to be your hand hygiene. And it's going to be important to just look at simple plain washing your hands can reduce your risk of infection getting transmitted from one patient to another, or else in the hospital based setting we could use a sterilizer, a hand sterilizer, which would be basically with an appropriate content. You have most of them floating around in the market, which may not have a content of what we would be really required to prevent infection. So that's something that would be important. Personal hygiene also is actually extremely important. So having a daily bathing, or if you're in the hospital and you're kind of bedridden, it's going to be important to clean the patient with the help of whatever is available in the form of wipes, disposal of the waste, looking at basic cough and respiratory etiquettes. These are simple things which would be required to reduce the risk of antimicrobial resistance. In hospital, we do have these patients with severe infection who probably would be a potential cause for an infection spread from one person to another. In these cases, we do follow what we call as an isolation practice.
Yeah, I think you've said practically everything. But what I need to remind the audience is we, as Indians, are very, very conscious and about hygiene. We just need to go back to what our grandmothers taught us as kids, and I think we'll be able to control and prevent a lot of antimicrobial resistance by preventing infections. The next question is what was mentioned earlier, Dr. Kirti. This question is addressed to you. What is the role of adult vaccination in the control of antimicrobial resistance? That's the last aspect that we actually need to deal with. Over to you, Dr. Kirti.
It's a very important but often forgotten aspect of diseases prevention. Like a preventive and social medicine is a last thing which normally as a medical student also we study. So, but it is very important because that will overall reduce the hospital visits, and in turn will reduce the exposure to the resistant multiple antibiotics and will reduce the resistance. So prevention is very important, and we need to revisit and reiterate that the vaccination is not only for kids, it's for adults also. So to just simplify it, the common infection which we discussed, Dr. Farah also mentioned, streptococcal infection, the pneumonia, when it is happening in elderly who have some problems like diabetes. Every third person in India is diabetic, or any other illnesses like chronic kidney disease, chronic heart disease. These patients are really susceptible to this infection and can have a very high mortality, like 1 in 6. A bloodstream infection of streptococcus pneumonia or pneumonia bacteria can have mortality if they are having other comorbidities. So, and there is simple prevention. We have a very good vaccine with a very minimal side effects available for it, which will prevent the mortality by at least 50%. More than that, actually, in the studies which have been published. So, it is just you need to be aware, you just need to be open, and you can make a rational decision by looking at the side effects, which are actually minimal if you see the number of people gets vaccinated and the side effect which they have. So you just need to go ask your physician, like, what are the vaccines required for my age, if you're of around 50s, or you can ask for your parents, take them for a routine visit and ask, like, what are the vaccinations required, what are the side effects, and when can we start. So I think from this, it should start and have a prevention, including it includes for hepatitis B. It's a very important vaccine preventable infection.
Dr. Kirti, I think I need to interrupt you because we're going to run out of time, and the last part is also equally important. So sorry for that interruption. So vaccination is important, and there are specific vaccines for certain conditions. Just to sum up, in a short period, we've tried to cover some of the important aspects of antimicrobial resistance that the community needs to be aware of. I think we can talk about this till the cows come home. But finally, I'd like to request each of our panelists to deliver a takeaway, one-line key message for all of you. Dr. Vaidya, can I hand over to you?
Yeah, thank you. So I would like all parents to realize that antibiotics are not a magic bullet to cure every illness in their child. And in fact, when used indiscriminately and without justification, they do a lot of harm both to the child and to the community. Thank you.
Dr. Anita Matthews, your one-line message, please.
Not use or overuse or abuse antibiotics, or else we will have nothing left to use in some years.
Thank you. Dr. Farah, can I request you for a take-home message?
You're on mute, ma'am.
You're muted. Dr. Farah, you're on mute.
Sorry, can you hear me now? See, my one-liner takeaway is use antibiotics for real battles. Misusing them will make them useless soon for you.
Thank you. Dr. Vaishali, over to you, please.
Thank you. If we use antibiotics when not really needed, they will not work when needed most. Thank you.
Dr. Kirti, last but not the least, over to you.
Think twice. It's better always to seek advice rather than using it by yourself.
Thank you, all the panelists. I think we've done brilliantly on time. We need to accept that. But I'd just like to have the last word by concluding that it's about using the right antibiotic for the right diagnosis in the right patient and at the right time. So on that final note, I'll leave you all. I think we have some way in which the audience can communicate with Fortis Healthcare in case you need any more information. I'm sure our team will reach out to you. So if you have any more questions or you want any more communications, we are open to that. Thank you to all my panelists for this excellent evening. I've thoroughly enjoyed it. And thank you to the audience for being with us. I hope it was a useful session. Goodbye, and thank you once again.
Goodbye. Thank you.